Welcome back to this video podcast edition of 12 Days in March. This material was delivered during a series of live lectures at the University of Massachusetts Medical School. In this installment, which is meant to follow the myeloma video, we will continue our discussion of bone tumors for the USMLE Step One exam. The topics addressed in this recording include osteosarcoma and Ewing sarcoma. As with all presentations, a PDF of this recording is available at the 12 Days website.
The goal here with the tumors are not to be exhaustive, and quite frankly, just the opposite, because when you get to bone neoplasm, there's a lot of tumors, but you don't have to know all the bone tumors. The tumors, the only ones really I wanted to pull out were myeloma, because there's so many derivatives of myeloma. I wanted to nail that one. Osteosarcoma versus Ewing sarcoma is an important distinction, because those are the ones that are going to come after you on. So that's what we'll cover. All right, so I know you got this table, and I'm distressed by this table. I'm not comfortable with this table. I'm comfortable with this. Osteosarcoma of bone origin. And so the key thing is bone origin, bone formation by tumor cells is diagnostic. So it's a bony tumor, and I am telling you, osteosarcoma, I'm going to beat it to death. You're forming bone. That's going to be that kind of hallmark, that pathognomonic feature. As opposed to Ewing's, gosh, no normal counterpart, and that's something. That's really a undifferentiated something. Unknown cell of origin. And so when you have these unknown cells, primitive, uniform, round cells, that's just great. So that's pathology for Ewing. And they're going to set you up. They'll describe the tumor, but the pathologies could not be any more opposite. Okay, here's his slide again, and what I like is this issue. We talked about the metaphysis for a reason. Metaphysis, that's where sarcomas happen. Ewing's, midshaft diaphysis. Key distinction. In that mid-diaphysis, you can see that onion skin appearance, onion skin, and look, I did some calcification there because you get this periosteal reaction. So Ewing is going to have some calcification too, but it's going to be periostitis, but associated with onion skinning as opposed to the blastic bone formation, that sunburst pattern, osteoblast of osteosarcoma in the area of the metaphysis. It's in the metaphysis because osteosarcoma in kids wants to happen in areas of rapid bone growth. All right, so now we'll come back to the bone tumors, and the only two, have a good time with the cartilage if you want to, osteochondroma, chondrosarcoma. The questions are few and far between. I think I saw one in the Q Bank this year. I don't think I've seen one in 3 years. So osteosarcoma and Ewing, that's why I focus on those. We already talked about onion skin diaphysis versus the metaphysis. And here you got to kind of remember these things. So Patrick Ewing was the great center for the New York Knicks. He played in Madison Square Garden, and whenever he came out after a game, he had a hot dog with onions on it, onion skin. That's very loose. I grew up in New York. I just happen to love those hot dogs. My nephew is looking for a job. I told him he should become a hot dog vendor. I think it's a great job, but he wasn't interested. So, I do this orthopedic perioperative work, and Matt Most is the oncologist there. There's a patient he saw. I can't even imagine the heartbreak. A 16-year-old guy goes sees his pediatrician. He says his knee hurts. The pediatrician orders a film, and it comes back with this lesion. And it's like, oh, my God, how do you tell that to a family? Here's the kid's bone scan lighting up at the metaphysis, and here's kind of a classic description. You don't have to read that there because we'll cover it. Young adults, especially during the growth spike, he was a 16-year-old, occur in the metaphysis, and the reason being because that's where we get the fast bone growth. So the majority, if they're going to give you osteosarcoma, is going to be in the knee. In terms of other situations, it's that Paget's disease. You don't have to worry about the mutations. There's too many of them, so there's no one classic. In terms of the pathology, again, there's multiple pathologies. What you just need to know that's a classic for osteosarcoma is this blastic activity. It's going to create bone. It gives this calcified appearance. That's pathognomonic for osteosarcoma. It's not specific, but it's pathognomonic in terms of being present. Bulky tumors destroy cortex, produce soft tissue masses, and they may be described that way. So if they talk about something in the soft tissue, it can still be coming from the bone, osteosarcoma. Bone formation is the hallmark, and we'll get to that. So here's that patient that we talked about. So here's this MRI where you can see that it's destroying the cortex. You can see calcification out here into the soft tissue. There's a soft tissue mass. Just in terms of driving home the point of this bone formation. So this kid, he was going to surgery. He was going to lose his leg, and his only chance for survival. He was going to get an amputation, and he had known pulmonary metastases. So he's going to go into the OR, and they're going to crack his chest. They're going to go into his thorax and his lung, and you know how they find the lesions? Feel for the lesions. They're feeling in the lung for these calcified lesions. okay? That's how they do it. And the guy had like 9 or 10, both lungs they pulled out all the mets. But my point again is this is not about this kid, it's about the idea of bone formation. So osteosarcoma metastasized to the lung, it's like little pieces of bone in your lung. That's how they dealt with it. Osteoplastic, I just want you to have that. And here's just a summary. Painful enlarging mass, check. Mixed lesions, unimportant for your purpose, other than the presence of the blastic part. Okay, one other thing they may describe, this Codman's triangle. It's not that important, so you have the sarcoma banging. This actually looks like it's in diaphysis, but work with me here. It's a tumor going into the soft tissue, and it actually raises the periosteum, and the periosteum gets calcified. So, and it's just referred to as Codman's triangle. It's just another one of those periosteal descriptions that go with osteosarcoma. And here again, I keep summarizing the diseases of the periosteum to be familiar with. So in terms of the pathology, there's a lot of different descriptions they can use, but just a classic description. Anaplastic cells that form osteoid matrix, new bone formation. All right, so that's osteosarcoma. I think I beat to get 1 point, new bone formation. Well, in a young guy at the metaphysis. I beat to death 2 points. Ewing, kind of similar demographic, but now we're in the diaphysis, still long bones, right? The idea that it's a primitive cell tells you you're not going to diagnose it on the primitive cell, but they may describe uniform small round cells without differentiation, so primitive. So that'll let you know. Again, if they give you that description, it's not osteosarcoma. The other problem is they're not going to do that. That's too straightforward. It has these rosettes of neural origin, and we'll look at that in a second. In the medullary canal, that's where they come from. So these are premature cells, neuroectodermal origin, rising in the medullary canal. So that's why they're in the diaphysis as opposed to the metaphysis. They may have constitutional symptoms, fever, fatigue, weight loss. Again, that's not going to be a deal killer for you on the boards. They have to give you something more juicy, like a destructive lesion in the diaphysis in a young patient with nonspecific pathology. And this too gives that periosteal reaction, so reactive bone in an onion skin appearance. And so just to compare and contrast, because we did reactive bone in Codman, diaphysis, homorosettes, and this is of neuroectoderm origin. So these will be the descriptions for Ewing's versus sunburst, Codman's triangle, new bone formation in the setting of osteosarcoma. They both can do periostitis, but they distinguish themselves nicely. And that's all I have to say. So homorosettes, neural differentiation. These tumors may arrive from neuroectoderm. Be familiar that Ewing's can be associated with this 1122 translocation. Patrick Ewing was number 33. How convenient. 1122, what was that other disease 1122 came up with? Yeah, DeGeorge, and that's a microdeletion, right? So 1122 DeGeorge, different problem. In this homorosette, I included it because, first of all, you don't even see it. Here's the Ewing sarcoma, just this uniform appearing cells. I just thought that was so pretty. I just don't want any of those in my body. And here's that onion skin. And distinguish in the humeral diaphysis, removed from the metaphysis. So that's Ewing sarcoma versus osteosarcoma.
And that concludes this discussion of sarcoma for the USMLE Step 1. Whereas there are many bone tumors, fixing your attention on myeloma and sarcoma will lead to big rewards on test day. If you have any questions or concerns, please email me at 12days. Thank you.